Welcome everyone to today's webinar, CPT 2021 Office Evaluation and Management Changes, sponsored by ABIO. I'm Morgan Hafner from Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. We look forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. It's now my pleasure to turn the floor over to today's presenters. First is Angela Jordan, the Senior CDI Consultant at Trusted I-10. Angela has over 30 years of experience in healthcare. Her experience includes EMR implementation, template building for physicians, providing documentation reviews to identify potential compliance risks, and providing education to physicians and their staff on applying practical solutions. This knowledge has allowed her to develop and present educational content for clients and specialty organizations. In the past, she has been awarded Coder of the Year, Educator of the Year, and Networker of the Year by the Kansas City chapter of AAPC. Also with us today is Amy Turner, Director of ABIO Advisory Solutions. Amy brings a widespread background in internal audit and healthcare management. She is a registered nurse, certified professional coder, certified in healthcare compliance, and a certified healthcare internal auditor. Amy's combination of clinical experience, coding education, and revenue cycle experience offer insights that speak well to both the clinician and the revenue cycle expert. Amy's experience includes working in large and small private practices, academic facilities, as well as hospital-based physicians. At this time, I'm pleased to turn the floor over to Angela to begin the presentation.
Good morning or good afternoon to everyone joining us today. As we dive into the 2021 Office Evaluation and Management Changes. During our session today, we're going to go through a guidelines comparison, preparing for the change, look at specific MDN language, and we do have included some leveling FAQs. So for those of you that work currently with evaluation and management, you're aware of the confusion that's caused by having different guidelines. We have CPT, which is produced by the AMA, the guidelines that are in the front of every CPT book. Then we also have the 95 evaluation and management guidelines that are a little less specific. And then in order to bring more alignment with the specialties, the 1997 guidelines were developed. And today, all three of these sets of guidelines are currently used. The current issues that we are aware of are the differing interpretations of these guidelines across payers, different audit tools that are used by each of the payers. We have a clear lack of definitions for terms in the guidelines as opposed to the differences between CPT and even the 95 and 97 guidelines, which in turn makes it difficulty to standardize for providers across healthcare systems due to these varying payer interpretations. Requirements to document elements that are not seen pertinent by the service of providers are burdensome. Physicians feel that the current guidelines that are in place often require them to document things that they don't feel are pertinent or even medically necessary to the reason they're seeing the patient that day. And so those of you that actually work on the payers or on the physician side or even the payer side in auditing, there's a plethora of different tools. And this is just an example of 3 different tools that I have used in auditing services. So the AMA listened along with CMS regarding all the physicians' complaints, especially as we transition from the paper record to the electronic world. Physicians were not ever meant to be typists. Now that's what they feel as though they're doing. But the current guidelines require them to document things that they don't feel are necessary. And due to the move to reduce the burden upon the physician, the AMA took on the challenge and they developed of not only their CPT editorial panel, but also the RUC Specialty Society to tackle these changes. And they came up with this solution. And this is, for those of you that work in the physician side, this solution is groundbreaking. This is the first major change since the 1997 Evaluation Management Guidelines. So the solution was published last year in November, and the AMA made not only the guidelines, but the new grid accessible so that everyone could start reviewing and taking in and trying to develop their plan on how to implement these changes. The big thing is that services are now going to be leveled either based on time or medical decision making, and the new guidelines provide very clear definitions for elements and terms within the guidelines. So the first major change is they dropped the 99201 from the new patient evaluation and management code set. And the reason why is because the 99201 and the 99202 had the same medical decision making. They were both straightforward. Now time in the new guidelines are going to be clarified as a range of time. It's not typically spent, which is what we're used to. Now, medically appropriate history exam are still going to need to be documented. The thing is that they're not going to be told exactly what they need for history and exam. It just has to be medically appropriate based upon the provider. And then another thing to take in consideration is now medical decision making or time is determined to use either medical decision making or time is going to be used to level the service. It doesn't have to be a threshold. It's based on whatever the physician chooses to document his service on. There's also additional clear guidance is being given to when comorbidities and underlying diseases can be counted for medical decision making. In addition, definitions for elements within medical decision making are given, which we did not have previously. So as we move forward, we're moving from what we're used to, history, exam, medical decision making, to either total time or medical decision making. So this is an example to the way the verbiage and the guidelines have changed. Now there is no more reference to history, exam, the level, or greater than 50% counseling and coordination of care, your typical time. Now it's a medically appropriate history and or exam, and in this case of a 99203 with low medical decision making. But then it goes on to say, if the provider is going to use time for the selection, they must document a total time of 30 to 44 minutes spent on the date of the encounter. So let's take a close look now at time. So we're moving from what we used to call typical time to now actual time threshold. So as you can see on this slide, if you have a new patient and you're spending, 10 minutes with a new patient, then time would not be appropriate because there is no 10-minute time threshold. But on a 99202, you would be coding that based upon the medical decision-making documented. The other thing that is new is that finally everyone listened to the physicians that, the time that they are spending on a patient pre-visit and post-visit on the same calendar date, they should be taken into consideration for the work that they're doing. So now it's the total time spent on the day of the encounter. So as you'll see by that previous slide, there is no longer a midpoint or threshold that's going to be used. They've got specific time increments. Now non-face-to-face activities count, and we'll look at that on the next slide. Code selection is used. There is not a required minimum MDM, and that is a question that we get often. In order to use time, does the MDM have to reflect the time used? No, it does not. But the provider is still going to have to document what they did in detail to support the time that they're reporting. Remember, typical time spent by clinical staff cannot be counted into this. So the time the staff is getting the patient ready to be roomed or asking the patient questions, it's not staff time. It's the time the provider is seeing the patient. Now, in instances where you might have what is called a split shared service, or let's say you have a physician and a nurse practitioner in the room and they're seeing this patient at the exact same time, only 1 minute can be counted per those providers. In other words, the nurse practitioner can't count 1 minute and the physician cannot count 1 minute. Now, this comes straight from the CPT guidelines. This is a list of all of the things that are considered non-face-to-face time that either the physician or the nurse practitioner or the PA, if they're spending time in these services, then they can count that time on the same calendar date of the visit. Now, on an AMA call, someone brought up the question, well, one of the things they say is documenting clinical information into the EHR is allowed. And the AMA said yes. The time that they spend entering orders or documenting their service can be counted. And someone on the call brought up, well, wouldn't that be benefiting a person or a physician that is taking longer to document than it would someone else? And basically what the physicians of the AMA said was really no, because if you have providers that are documenting time constantly, but then you have other providers that are using MDM appropriately, the physicians that are probably using MDM are going to benefit far greater than the physicians that are documenting on time, because the physicians that solely using MDM and getting the details of their notes are most likely getting more patients seen throughout the day. So time may not always be the best use in a service. So there's going to be a brand new prolonged service code. The code is 99417, and this code is for 15 minutes of time. Now, what is interesting with this new code is that it can only be reported with the highest code, either a 99205 or a 99215. It cannot be used in conjunction with any of the other prolonged service codes. And this code is only reported when each 15-minute unit has been met or exceeded. And here is the example of the time grid that is in the AMA 2021 CPT Professional CPT book. And it shows you at what time increments you would be able to bill out the 99417 and additional units thereof. Now, the one thing we don't know, this is what the AMA is saying. We do not have the CMS final rule yet for the Medicare fee schedule. So once that comes out, the proposed rule said a minimum of 89 minutes must elapse for the 99205 and a minimum of 69 minutes must have elapsed for the 99215. Since the final rule won't be out possibly until the first part of December, we will have to wait and see what they provide us. So now let's jump into medical decision making. So now the history and exam only have to be medically appropriate per the treating physician. So you could see where this is more beneficial, especially in practices where, let's say your patient comes in for their annual visit and they've had all of their lab work done. And so on the next visit, they may not need that entire physical exam, but maybe that next visit is to go over some abnormal labs. So the physician now is entitled to document whatever he feels is appropriate. So this is where the standardization really kicks in. In the MDM, the AMA has provided us with a brand new method. And this is, they call it Table 2 in the Evaluation and Management Guidelines, and this is only to be used, and I'm going to stress this again. This is only for office and other outpatient E&M services. So this is only for 99202 through 99215. This does not affect skilled nursing. It doesn't affect hospitals because these codes are not used in those settings. So as we look at the grid, you'll notice that it still contains the 3 parts of medical decision-making that we use today. The first column is the number of diagnosis or management options. The second column is data, and it's the amount and or complexity of data reviewed and analyzed. Our third column is the risk of complications and or morbidity and mortality. So what does this all mean? It's essentially what you're currently used to. However, if you look in these 2 columns here, they have expounded upon what they're going to be looking for as far as documentation is concerned. So now it's the number of complexity of problems addressed at this encounter. For your data, just simply reviewing it isn't going to be enough. You have to show that it's been reviewed and analyzed, or how the review of those either labs or tests, how they are going to apply to your treating the patient today. And then the last one is the morbidity and mortality of the actual patient management. The other thing you'll notice is by getting rid of or deleting the 99201, now our codes align. So your 202s and 212s, whether it's new patient or established, it's still straightforward. So that is not going to have a bearing like it you did before. Your code sets are going to align. So as we get into the actual guidelines and the definitions, the number and or complexity of problems addressed at the encounter. And they've done a lot of detailed work in explaining when certain problems can be counted toward leveling your service for your medical decision-making that day. So I'm going to have Amy step in here and give some guidance from a clinical background.
Thanks, Angela. Thank you, everybody, for joining us today. So with the changes they've made, when we start talking about this number and complexity of the problems, one of the things that I think providers are kind of in the habit of is that they will list a symptom as a diagnosis, not necessarily the unique condition. So, for example, say a patient came in with low back pain, and you know that they have spinal stenosis. That is spinal stenosis. The low back pain is inherent to that. So that's not going to be something that you're necessarily going to want to list separately. If the symptom is part of the diagnosis, that's not going to count as different diagnoses. When you think about the comorbidities of the disease, of patients' diseases, you know, unless it's something that you're addressing or the presence of it is really changing the complexity of your treatment of care, that's not going to be something separate that you're going to use to the level of E&M service. So, for example, you know, if you've got somebody that's diabetic and so they've got bronchitis and you're putting them on steroids, well, because you're putting them on steroids, that could end up affecting their blood sugar. So in that situation, a comorbidity is applicable. The other thing is when you think about the final diagnosis, you know, that it's not going to determine the complexity or risk in and of itself. Just because you have a highly complex diagnosis, you know, what was your evaluation that was done and the signs and symptoms? So you've got to make sure still as you go through, you know, you have to have that problem pertinent exam. If you've got a really, really high complexity diagnosis and your exam is something really simple like, you know, alert and oriented and, you know, in no acute distress, those couple of things don't actually match up. So you've got to really take into consideration all of that. And then just because, you know, you can have you can have lots of lower severity diagnoses, but when you look at that as a whole, that may actually create a higher risk because of different interactions. You start somebody on a new medication that may affect this situation that they already have, or, create a side effect like we talked about with the steroid just a second ago, that then you've got somebody who's in trouble with their blood sugar. So, you've got to think about the big picture here. So when we think about, again, under this category of number and complexity of problems addressed, when you think about the problem that is being addressed, it's being addressed when it's evaluated and treated. So you can't just merge the whole problem list over and say, okay, here's all the problems that I'm addressing, because you're not necessarily addressing all of those problems. Those are problems that patient had, but that doesn't mean that that's a problem that's being evaluated in that encounter. And that's what goes into selecting your code. It's what are you actually treating on that encounter? What are you testing? And you've got to make sure that those things are documented. So documented that you can't just say, diabetic. Well, what about their diabetes affected this encounter? Or hypertension. What about their hypertension affected this encounter? So you've got to make sure that it's being addressed and managed, not just the list of problems that the patient has. Similar to that, when you think about making a referral to another specialty. So you've got a patient that say you're going to send out for a psych referral. Well, how did you come to that decision? You still have to document that you evaluated that. What's their history? What kind of exam was done? What kind of diagnostic study? So you can't just you don't want to get to the end of the visit and say, refer to psych. Well, why are you referring them to psych? Did they have a mention of being suicidal or, really depressed? And what did you do to try to manage that particular situation? So you've got to remember that your E&M visit is basically kind of think of it like a storyboard. You can't, if you don't clearly tell me what's happening in chapter 1, when I get to chapter 4, I'm going to be lost. And that's what you've got to make sure that you've got in these visits, even with these changing guidelines, is that continuity, that someone can follow it and they know what is happening. And that's important. And it's just, it all boils back down to documentation. So let's go back to Angela and let's start talking about some of the details of these guidelines.
Okay. So we're going to jump right in and we're going to look at the medical decision-making grid, and we're going to look at what is straightforward. The straightforward are going to be your new patient and established patient codes 99202 and 99212. So you will see that these pretty much mirror identically to what we currently have now for medical decision-making. Your number and complexity of problems addressed are going to be minimal or like a self-limited or minor problem. You'll notice that there's minimal to no data required and that the risk or complication of morbidity, mortality is minimal risk without additional testing. Now, one thing I did want to impart to you was something that I learned upon one of the AMA meetings I listened to. And the thing is, if you looked at the new grid, you realize that under straightforward and under low in the risk column, they did not list any examples at all, like we're currently familiar with on our table of risks. And it was really interesting. Someone asked the question, and it was a clinician, and they said, well, we like the table of risk we use. Can we just take the examples that are in the current one, and when we build our own tool, can we add it to the table? And basically what the physician on the call stated was no, there was a specific reason that they didn't do that. And that was because that level of risk was left up to the physician or the provider of the service because they had realized that sometimes their thought process could actually be higher than that. And they brought up the sample of an over-the-counter drug. And they said not all over-the-counter drugs would be considered low medical decision-making or a low risk, and that's because a patient could have another either condition or another medication that would actually interact and actually make the problem moderate or possibly even high in some cases. So the AMA strayed away from actually putting any examples into straightforward or low. So as we look at low, you'll notice that it says you must meet 2 or 3 of the medical decision-making elements. So if you look at the guideline definitions, it's pretty straightforward. They're saying, number 1, a minimal problem might be one that you would not even need, you wouldn't need to see a physician for, but the patient might see under the presence of a qualified healthcare professional. So they even go as far as to say, you know, these might be your services that you would consider using the 99211, and some of those refer to those as nurse visits. Then they give the definition of a self-limited or minor problem that runs a definite and finite prescribed course that is not likely going to permanently alter health status. And that's an area where you might think of those, you know, it's summer and your kids got into chiggers or they've got bug bites. Sometimes you can treat those, you know, perfectly fine at home, but there are other times you just want to take them in and get the nurse or get the doctor to just say, you know, just reassure me that this isn't anything. Some even refer to, and I've been on Medicare calls where your simple common cold that is just, it doesn't run a prescribed course. It's just pretty transient. It's there and it's gone. They even consider that a self-limited or minor problem. Amy, do you have anything you'd like to add regarding a self-limited or minor problem?
Nope, I think you've got those. You know, like Angela said, it's a, you know, a bug bite you're worried about, a reaction that you had. I've literally had somebody that had a, you know, they had a flu shot and the site of the injection was red a couple of days ago and they wanted that evaluated. So, I mean, it's something that's pretty finite.
Okay, then as we move on to low, which is our 99203 to 99213, we still have the same requirements as we go through to meet 2 of 3 elements, but this is where things start to build. So you'll look at number and complexity of problems that are as addressed. Those are actually similar to what we have now in our MDM table. But this is where things really start to change up, and this is where they made the most drastic changes to medical decision-making, and that's the amount and complexity of data reviewed and or analyzed. So as you look at this slide, you'll see that in order to fall into this category, you must meet 1 of the 2 categories. And our category here, or category 1, is tests and documents in any combination. You must get 2 of the following, or it says here category assessment, but then there's a note that says for an independent interpretation of tests and discussion of management of test interpretations, see moderate to high. So they're automatically telling you if you've got something that falls into category 2, assessment requiring an independent historian, don't even look here, don't go any further, go to category for moderate or high. But what is unique about this is it's each unique test or it's each unique order or it's each unique review of external notes from each unique source. And then here we have, like I said previously on low, they did not give us any definitions for the risk or complexity of morbidity and mortality. So as we look at a stable chronic illness, and this is something that I think a lot of us that have worked with physicians need to really get with them and make them understand, is that within the guidelines definitions now, they've actually been very, that they need to realize that stable and a patient that has not at their treatment goal is not stable. And so verbiage and the use of specificity in their assessment plan is going to be even more important. And so from a clinical standpoint, I'm going to have Amy jump back in here with these definitions.
So what I think we want to think about here is, a stable chronic illness. So, you've got to think about the definition of chronic as related to these E&M guidelines. So this is going to be a problem that's, going to be around at least a year, or until, unfortunately, the patient passes away. They define stable as that the patient has met their treatment goal. So if you have set a goal for a patient of a hemoglobin A1C of, I don't know, I'm going to make something up, 5.6, and they are stable, they are hanging around 6.2. So you've got to think about that, okay, what you set for the patient's goal and where they are is not at the same place. So that means if you're not at goal, you're not stable. Even if, say they were 8 and they're down to 6.2, okay, well, that's definitely much better. They give us specific verbiage where they give us examples of well-controlled hypertension, a cataract, some benign prostatic hyperplasia. But also here you want to think about your acute uncomplicated illness. So that's going to be, say somebody's got a bladder infection or some kind of rhinitis or a simple sprain or strain that with some ice and whatnot is going to resolve itself. So, pretty straightforward information.
Okay, so
yeah, go ahead.
Oh, sorry. So as we move on, this is where things really are, like I said, have gotten interesting. So they realize that each test that a physician orders actually kind of builds upon the complexity of the issue. So now the physician gets to count every test they order. Now, it's a test that's ordered is defined by a CPT code. So if a physician orders a CBC, that's one test. If they order a urine culture, that's one test. Now, if they order a basic metabolic panel, which is a panel of multiple tests, because it's defined by one CPT code, it is a single test. The same thing goes with a bilateral chest X-ray. The same thing would go with a CT. As long as it's described by a single CPT code, then that would be a single test, imaging, laboratory, psychometric, or even physiological data. Then external records are identified or defined as external records or communications from an external physician outside of your facility or healthcare organization. So records within your own organization would not be considered external records review. It has to be from an external source outside of your facility or healthcare organization. Now, it can be also considered someone that is not your specialty. Then an independent historian, and this has gotten a lot of questions around it because they are now giving points for an independent historian who is an individual, and they clearly state it as a parent, guardian, surrogate, spouse, or witness who provides history in addition to what the patient has provided that is reliable. And they go on so far as to, so if they're giving history due to the patient's developmental age, the patient isn't able to do so. Or you've got a parent with psychosis or Alzheimer's and you're giving the history. That can be counted, and in order to make it countable, the physician would need to identify in their record who is giving the history and what history did they give. So the amount and or complexity of data reviewed and or analyzed. So this is where there's been a lot of Q&A and FAQs going on around this, and the AMA CPT Symposium is in a few weeks. And I hope that we get a lot more insight in this because there is several different discussions going on regarding what can be counted and when, and it's all because of this information in the CPT book right here. So the ordering of a test is included in the category as a test result, and review of the result is part of the encounter and not the subsequent encounter. So the question is, if I order a chest x-ray today and I get the result back and I review it today, can I bill for the order of the chest x-ray, and can I also get a point for the review of the chest x-ray from the radiologist? Well, the issue is that they're saying that anything that you order, or at least the interpretation of this, is that anything you order, the review of that test result is part of that encounter that day. So if you got the test result back for the x-ray, but you didn't go over to the next visit, you can't count it at that visit because it was included in the order for that day. So that is something that we're looking for additional guidance on. But the one thing that we do know is that if you have the ability to, let's say you have an EKG machine in the office and you are ordering the EKG that day, and not only are you ordering it that day, but you're also billing the 93000 for the interpretation of the report, you can only count 1 point for the order because you are getting reimbursed for the interpretation because you're billing out that service. And that is covered under the separately reportable service that cannot be counted in the MDM. So anything that you're doing in the office on the date of the encounter that you would document an interpretation and report for and would be able to bill for it, then you would not be able to count that in your MDM. The same thing goes for any of those discussions of management with a physician or other qualified healthcare professional outside your organization. There are some CPT codes that you can bill out for those type of conversations. If you are doing that and you are billing those codes out, then you cannot count those discussions or management options within your MDM. So now we're going to jump into 99204 and 99214, which is our moderate. Same thing here. Number and complexity of the problems addressed are pretty much identical, but the amount and complexity of data has changed because now we have 3 categories, and you have to meet at least one of the 3 categories to be able to bill moderate. And so this has changed from under category 1, instead of having to have 2 of the elements, now you must have 3. Then under category 2, you have your independent interpretation of tests performed by another physician, or now category 3 is you have discussion of management or test interpretation with an external physician or source. So that's where data now has changed. Instead of having only 2 categories, there are 3. You only have to meet one of these. But for the category 1, instead of 2 tests or 2 elements of this, you now have to have 3. Now, this is where risk and complications of morbidity and mortality look the same. The big one here that is important is the addition of diagnosis or treatment of significantly limited by social determinants of healthcare. So separate services, we've kind of gone over this
Angela,
already a little bit.
This is
Yes,
where we
Amy.
have a slide that's actually out of order. I think this is the slide we need to be on.
Okay, thank you, Amy. So, Amy, I'll let you go ahead and take this since this is more from a clinical standpoint.
Sorry, guys, about getting that slide out of order, but we'll get back to that one in just a second. So when we talk about a chronic illness with an exacerbation, let's think about somebody that is an old COPDer, and they come in, it's it's cold season, they've been around somebody smoking or whatever, but they've got, an acute COPD exacerbation. That's your chronic illness as defined earlier. That's going to be there forever. So you've got a chronic illness, you've got an exacerbation. Or if you have an undiagnosed new problem and you're not exactly sure what the prognosis is going to be. So think, somebody that comes in with a lump in their breast, you're going to go through with a biopsy. You're not sure where that treatment is going to end up. Then you can have an acute illness with some systemic symptoms. So think, a really bad pyelonephritis, a kidney infection. If this is someone that, are they going to end up in the hospital with IV antibiotics? So it's not just a kidney infection, that you can treat at home with some Cipro. This patient may have to be admitted and have some IV antibiotics. Or you can have an acute complicated injury. So say some type of head injury with a brief loss of consciousness. That would be another example here of how these guidelines can be met. So the next slide that we're going to talk about is going to be these interpretations and with external physicians and whatnot. I'll let Angela take back over on this part.
Okay. So they've gotten very specific about, because they are aware that on a daily basis, physicians are looking at their own records from their group. And they've been very deliberate that in order to count points for certain things that are reviewed, they've been very deliberate with this has got to be an external physician or other qualified health professional that is an individual that is not in the same group practice or is a different specialty or subspecialty. And they go on to elaborate that they're practicing independently, maybe a facility or an organization such as a hospital, nursing facility, or even a home health care agency. So an independent interpretation is that it doesn't have to follow the same guidelines of what someone of that specialty would do, but it would be that physician's interpretation of something that they've received from outside that they are not separately going to bill for. So it could be someone brought in an MRI from an outside source and they're reviewing it, they look over it, and then they document their interpretation or their impression of the MRI and how they're going to use it in their treatment. Then they give the definition of an appropriate source. And an appropriate source is someone who is not a healthcare professional, but is ultimately involved in the management of the patient. And the examples that they give are ones that most of us are familiar with. You've got teachers, case managers, it could be an attorney, but they do go on to say that this is not an informal caregiver. So it's not like a family or a family friend or someone like that. The big one that I think the area most people could start working on with their providers now because it's such a big key buzzword is social determinants of health. Right now, there are a group of ICD-10 diagnosis codes that reflect economic and social conditions that affect a person's health within their communities. If we are good and we can get our physicians on the dates that they're seeing these patients to document if their patients are actually encountering one of these social determinants of health, that actually, and how it's impacting their healthcare management, that will actually boost, from a risk standpoint, it will boost them up to moderate medical decision-making on the risk table. Oh, thank you, Amy. So now we're going to go to 99205 and 99215. So we're now to high medical decision-making, and this is two of three key components again. But now, if you look into data and complexity of reviewed and analyzed, if you're looking at this category now, you will see that you have to get two of these three. So you either have to have three category one, which are test enter documents, something from Category 2 or Category 3. It could be Category 2 or Category 3 or Category 1 and Category 3. But this is where you have to meet 2 of 3 within data and amount of complexity analyzed, in addition to one of the others, which could be your number of complexity of problems addressed and or the risk of complications and or morbidity and mortality. And so as we move on to the next slide, so chronic illness with a severe exacerbation, they have included in this that this is your patient that might have a significant risk and may require hospital level of care. So this might be that patient who is having a severe COPD exacerbation, and you are going to you're trying to stave off hospitalization. So within your plan of care, the physician has something that they're going to try, maybe some breathing treatments or a new med, and if they're not improved within 24 hours, they're going to be hospitalized. That is the type of person that would fall within the high for that chronic illness of severe exacerbation. Now, your acute or chronic illness or injury that poses a life or threat to limb or body, these are going to be the ones that are currently in our current table of risk. They give examples of, acute renal failure, abrupt change of neurologic status. I don't know, Amy, do you have something that you would like to include here?
This is going to be your patient that really is coming to the office. You think they're having a myocardial infarction. They're having chest pain and short of breath. You think they're having a pulmonary embolus. They've got something going on that, a hot, possibly ruptured, appendix, something that is posing a threat to bodily function. They came in, their blood pressure's out the wazoo, and they have slurred speech and numbness and weakness on one side of their body. It looks like they're having a stroke. These are people that need some immediate attention is what I would go with for these. One of the things that we also want to talk about related to this 99205 is drug therapy that's requiring intensive monitoring for toxicity. So this is going to be for patients that, they're on a medication that requires that intensive monitoring to make sure that they are within the correct range so that you don't get into any adverse side effects. So you're looking at this range. So say you go back to, thinking about medications like, digoxin, your theophylline, some of your psychiatric medicines, your lithium levels, that kind of thing, to make sure that even sometimes with your possibly your peaks and troughs on antibiotics, you're monitoring this level to keep the patient from having some kind of serious side effect. Now, if you're monitoring this just by patient history or exam, that's not going to qualify. It's got to be something where you're doing this lab work. Now, this is not going to apply to like urine drug screening. This is medications, and they give us the example here of what doesn't qualify would be glucose monitoring, while they're on insulin, or annual electrolytes and renal function. That's not going to qualify. This is those things like those medications I mentioned, phenobarb, your digoxins, your theophylline, lithiums, those kind of things that you need that level, or somebody comes in and they're having some adverse side effects because possibly they're a little high on the level and they're, starting to have some of those symptoms. Those are things that have to be monitored. And that's just some of the medications that these people are on, but that does apply here for sure. So the next thing we'll talk about, and I'll let Angela talk about this, is the separate services.
Okay, so the rules are still going to apply. Nothing has changed about modifier 25 and when you have an E&M with a procedure. That all still applies. What they're specifically being very clear about with separate services If there are things that you're going to bill out that has a professional component, you're still going to be required to either append the modifier 26, and that would not be counted within your medical decision-making level, you know, in addition to those services that have the pre-built-in E&M. You're still going to have to follow the same rules and only report the separately identifiable E&M if it's supported. So now we're going to really quickly just go over the importance of proper and compliant MDM language. What we need to work with our providers is making sure that they're using language such as not at goal, not improving it as expected, giving the detail behind the medications they're prescribing, and staying away from using terms like refill all meds or continue meds or labs were ordered without a correlation to why those labs or orders or medications, what they were actually needed for, and how they're going to impact the care. The other question we get asked is, how is this going to affect reimbursement? Right now, everybody is trying to figure that out. But from the reviews that we've already done internally on the assessments that we've done, one thing we can say for sure is look at your current documentation of your providers, look at their assessment and plans. Are their assessment and plans clear? When you read them, do you know exactly what occurred that day? Do you know the status? And do you know what the physician is going to do in the future? Or is it like a story that's got a lot of blank sentences and you need to fill that in? Well, we have found that the providers that have the better assessment and plans are faring far better because they're detailing what they're ordering and what they're ordering it for, what they reviewed, how it impacted their care, comorbid conditions and medications that are having an impact, versus providers that are using templates and macro statements that essentially say refill meds, continue meds, or labs ordered today, patient stable, see you in 3 to 6 months. So we're going to look at an example of the 2021 guidelines actually applied. So with the software, you can see where we have a note, and this is an actual provider's note for a patient that is coming in for a follow-up of a couple of chronic conditions. And you can even see here that there was a discussion of counseling and coordination of care was greater than 50%. You see past medical history. And then what we did was the exam was appropriate, but here's what was ordered. So you can see that the physician ordered CMP and lipid panel for the mixed hyperlipidemia. The patient was concerned that he might have had COVID, and so he wanted a serum test to see if he had antibodies. And then also the encounter for the PSA. Then you have the diagnoses with the plan. So you've got that he wants this patient to continue his low-fat diet and his Crestor, and you have some other diagnoses here. They had a discussion about the shortcomings of the test for COVID. You have PSA ordered as requested, and then you have this assessment and plan. So based upon what we have here, you can see that the patient has 2 or more stable chronic diseases, and that came into moderate on problems addressed. So then when we take into effect that he ordered 4 individual labs, we have that he qualified for moderate under data reviewed, ordered and reviewed, because he had 3 unique tests as identified by a CPT code. He didn't have anything for category 2 or category 3 that would boost him up to extensive. Under category 4, pain management, we have the prescription drug management because he did review his hyperlipidemia, and that he does want him to continue with the current Crestor and low-fat diet. So when you look at how this visit scored, it scored as a 99214. Now, the one example here is it did catch the greater 23 minutes face-to-face with 50%. The software did catch it and labeled it as a 99213, but we know that this is not going to be a compliance statement come 2021, because in 2021, if a physician is going to document time, the greater than 50% counseling and coordination of care doesn't matter anymore for office and outpatient services. So the provider would want to document his total time. So let's jump in. I think we can open it up for some questions and answers.
Great. Thank you both for that fantastic presentation. You know, I think we do have time for a couple of questions here before we wrap up, so I want to get to those as quickly as possible. So ask one question. You know, some person has a question about, you know, influenza testing specifically, and they're curious. Influenza A and B testing is billed with 2 units of 87804. Is that considered one test or 2?
Ooh, that's a new question for me.
Me too.
And we can go ahead and jump into a different one. It is a very specific
you know
question.
What? That's actually a great question.
Let's research it, and then can we just send an email to all the attendees with that answer? Because that's, I think, especially with what we've got going on right now in the world with all this testing, that would be probably a beneficial question to answer for everybody.
Agreed.
Absolutely. We have one more question that's a little less specific than that one, and I think it's also a really good one. And it's, you know, do you know what payers will be following these guidelines besides traditional Medicare?
Well, because of the HIPAA codes, all payers will be following these as they were published in CPT already. So these are going to be the rules for everyone because of the HIPAA code set rules. So all the payers will be following them.
Got it. Excellent. And let's ask one more question today before we wrap up. And that is, can we do a preventative wellness visit with an E/M visit?
Yes. The rules still apply as they do today. So as long as your preventative services and you have a separately identifiable, you know, problem-focused evaluation and management service with its own unique, you know, in this case, appropriate history and exam and its own medical decision-making that stands alone, then yes, you can still do an E&M with a preventative as long as you're using the proper modifiers.
Got it. Excellent. Well, before we wrap up, Amy or Angela, do you have any final thoughts to share today?
I would just like to say, you know, thank you all so much for joining us. This is really exciting, and as we move forward, it's really important to start looking at your documentation, look to do assessments. We actually offer the assessments that will look at your current documentation and how it would fare in 2021. So we highly recommend that you look into doing that. Amy?
Just, you know, thank you to everybody for being here. I think this is, you know, this was a lot of information presented in a really short period of time. So please feel free to reach out to Angela or myself if you have any questions. You know, we know there's going to questions after questions after questions. I think one of the big things for providers right now is just making sure that they are actually documenting what's going through their brain, and it makes it actually to the note so that they are getting all of the credit that they deserve, you know, for what's going into these office visits. And I feel like from audits that I've done, you know, historically, some of those things, you know, they may have thought about the social determinants of health, but that's what they need to get on paper now. That needs to get in the records because that is going to make a difference. But I do think, you know, like Angela said, one of the things that we're offering is, you know, take a minute and compare what your E&M coding is now to how that's going to code in 2021. You may end up with a revenue impact, you know, and it could be negative. So I know it's the beginning of November, but it's never too soon to start evaluating those things for next year, and looking at what does that documentation look like, and are there little things that we can help the provider get on paper to hopefully minimize any type of revenue impact. So I don't think it's too early for anybody at this point to go ahead and be proactive with some auditing on, you know, current state and how that looks in future state and how that's going to affect things. I know one of the announcements that we needed to make was that you guys will be getting emails from us at ABIO with your CEUs, so keep an eye on your spam folders just in case that gets hung up somewhere.
Excellent. Sound advice and observations from both of you. Thank you again. And thank you, ABIO, for sponsoring today's webinar. Everyone, please enjoy the rest of your day, and we look forward to having you join us for future webinars.